Hello, my name is Michelle Mulholland, and I'm the founder and CEO of the OPMD Association. Thank you for joining us for this informational webinar presented in celebration of International OPMD Awareness Day. In the fall of 2022, I began the process of establishing the OPMD Association. I wanted to create an advocacy organization in honor of my paternal grandmother, who passed away from complications of OPMD, and to serve the OPMD community, whose members' lives are greatly affected physically, financially, and emotionally due to this rare disease. The OPMD Association is an all-volunteer advocacy organization that provides information, support, and resources to the OPMD community. We strive to raise awareness of OPMD through education, networking, and partnerships. Our goal is to promote and support treatments and eventual cures for OPMD. In today's webinar, you will hear from OPMD clinical and industry experts, and two people living with OPMD will candidly share their OPMD journeys. At the end of the webinar, we will provide you with a list of resources and volunteer opportunities.
Dr. Wickland, thank you for being with us today. So we get lots of questions in the OPMD community about real basic things about OPMD, what it is, what causes it, symptoms, the progression of the disease, approaches to treatment, exercise, diet, nutrition, what steps to take. And I'd love if you did an overview today of all those things.
All right, that sounds great. So we'll start with what is OPMD, or Oculopharyngeal Muscular Dystrophy, and it's a late onset muscle disease that is associated with drooping of the eyelids, which is called ptosis, trouble swallowing, which is dysphagia, and then weakness of the muscles of the legs and the arms, and so that's the myopathy part of it. So oculopharyngeal muscular dystrophy, myopathy, or muscular dystrophy. This was first described in the medical literature in 1915 in a French-Canadian family. But when you look around the world, there really is OPMD around the world with different prevalences in different locations. But there are pockets where OPMD is much more prevalent, and those include in Quebec, Canada, so French Canadians, where it's roughly 1 in 1,000 people have oculopharyngeal muscular dystrophy. In Israel, the Bukhara Jews have about 1 in 600 people have it. Interestingly, the Canary Islands were sort of a launching point for a number of places in South America and Mexico. There is about a 1 in 10,000 prevalence. And then closer to home here in the United States for us is that in the southwest of the United States, there is a much higher prevalence in the Hispanic population of the southwest of the United States. So there are genetic causes for OPMD, and it is a genetic disorder. And it's important to know that this is almost always, not always, but almost always inherited in an autosomal dominant fashion. What that means is that you have 2 copies of each gene, and 1 copy is abnormal, and that can be passed on to 1 or more of your children. And there's a 50% chance that they will get the 1 copy that's abnormal, and a 50% chance that they'll get the copy that's normal. There are rare cases where there are 2 abnormal copies in a person, but that is probably only 1 to 2% of disease. So we're going to mostly talk about just the autosomal dominant. So the gene that's involved in OPMD is the polyadenylate binding protein nuclear 1 gene. It just rolls right off your tongue. It's much easier, PABPN1. And what's important about that gene is that if you do not have OPMD, there are 10 of what are called a trinucleotide repeat, and these are only 10 of them in somebody that doesn't have it. But if you have 11 or more, usually 12 to 17 copies of that trinucleotide repeat, then that will lead to oculopharyngeal muscular dystrophy. There is some evidence that the larger the repeat size, the more severe or earlier an onset of disease, but that does not always hold true across all different populations. So in general, we should just think that if you have OPMD, you have OPMD, and there are probably genetic factors that will cause it to be different, even in different family members within the same family. So the common symptoms that occur in OPMD are just as it's described, which is oculo, which is the eyes, pharyngeal, which is swallowing, and then muscular dystrophy. And so the drooping of the eyelids comes on usually in the late 40s, but that can range anywhere from the 20s all the way up until the 60s. Usually not long after that, but occasionally before that, is trouble with swallowing. That's the dysphagia, and that has onset usually in the early 50s, but again, can be as early as the 40s and as late as in the 60s. And then the third manifestation is the weakness, and that's weakness generally of the lower extremities, and that tends to come on maybe 5 to 7 years after that. So onset around 60 years of age, but again, it can be as early as the early 40s and as late as the 70s, or some patients don't ever get the weakness in their skeletal muscles. It's kind of important to remember that it's not just the muscles of the arms and legs that can get weak, but interestingly, muscles such as the tongue muscle is commonly affected, and that can lead to problems with swallowing, but also with problems with enunciation, so that the voice may become a little bit less of your previous voice, and you may have trouble making your voice clear. There also can be eye movement abnormalities, but generally they don't affect people as much as the drooping of the eyelids. And occasionally facial muscles or arm weakness occurs, but generally the weakness is more so in the lower extremities. Probably 30 to 50% of patients in their lifetime will need to use something like a cane or a walker to assist them with walking, but many patients still walk independently throughout their lifetime. And probably about 10 to 20% of people with OPMD may wind up using either a scooter or a wheelchair at some point, whether it's just for distances or for full time. For me, what's important about my patients is that the life expectancy is normal. So that's important, and especially if all the symptoms are adequately managed. So how do we diagnose oculopharyngeal muscular dystrophy? There is a clinical way to make the diagnosis, and I'll briefly go through that, and that is by the time somebody is 70 years of age, 99% of people with OPMD will have drooping of the eyelids of at least less than 8 millimeters open. They will have trouble with swallowing, such that just 3 ounces of water, it'll take them more than 8 seconds to swallow. And they'll have a family history of 2 or more generations of people involved. And so that means parents or children or uncles, somebody will be involved that you know about. And so that's 99% by the age of 70. But what really matters around the time of diagnosis is, what do you have then? And the answer then is it's only about 30% of the time that you'll have all 3 of those at the time of diagnosis. So then you have to look for other things, such as, is the drooping of the eyelids something related to it or not? Is it trouble swallowing related to it or not? And that's where sometimes the diagnostic journey is delayed a little bit in making the diagnosis, unless it runs in the family and everybody kind of knows that it may be coming. Diagnosis, though, truly nowadays is just by doing genetic testing. And genetic testing is much easier, cheaper, faster than it's been even in the last 5 years. And so nowadays there are sponsored testing programs that do test for oculopharyngeal muscular dystrophy, which allow us to make the diagnosis fairly easily just by doing a mouth swab and getting genetic testing done. So once you're diagnosed, then, well, actually, let me go back. Why does it matter if you're diagnosed or not? You are who you are. You're going to live your life. You're going to live your best life, and that's important. But it is important to have a diagnosis, and probably going forward, the main reason I think that's going to be highly important will be because most of the treatments that will be more definitive are going to be gene-based therapies. And currently, all our gene-based therapies for neuromuscular disorders, you must have a genetic confirmation of diagnosis to get that treatment. And so that's one of the first easy reasons to make sure you have the diagnosis. The second is to make sure that you don't have something else, which occasionally people can be fooled. And then thirdly, once you've got that diagnosis, you pretty much know what your path is going forward. So once you're diagnosed, what is maybe the most important next step to do, and that is, in my mind, you need to get your family, which is your community that has OPMD, and that is where the OPMD Association is very important. You need to have people that you can bounce things off of, you can ask questions of, things of that sort. And the second is you need your care team that's going to be people that understand oculopharyngeal muscular dystrophy, that are aware of the nuances related to the eye involvement, to the nuances of how do you manage the trouble swallowing. Are there things you can do to optimize the ability to get around in the world? And that really requires people that understand the disease itself, and not just any person that takes care of swallowing or an ophthalmologist. So in terms of treatment, there is treatment for drooping of the eyelids, and that term is called a blepharoplasty. And I'll be honest, I don't try to know all the different techniques that can be done, because there are several different techniques that work in different ways for patients that have ptosis. So the blepharoplasty, I usually leave that to my ophthalmologist who does blepharoplasties. And importantly, though, I have an ophthalmologist that knows what oculopharyngeal muscular dystrophy is, so they know that this may not be a one and done. It may be that they need to do it so that they can do it a second or third time 5 or 10 years later, and then 5 or 10 years after that. And so that person is important to be part of your team. Swallowing is one of the bigger issues that can get in the way of life. And so then the key is, what do you do about that? And the answer is, there are ways that you can help with swallowing. The first way is just to get it diagnosed and maybe have a swallow evaluation and a swallowing study with a speech therapist. And sometimes just working with them, they can allow you to do non-invasive things that will help you swallow for 1, 2, 3, 5 years without any intervention at all. However, after that, then you may need to have something done. The most definitive thing that can be done is what's called a cricopharyngeal myotomy. And what that is essentially, it just allows the muscles in the throat to be a little bit more loose, so that when you go to swallow, gravity helps it flow down, and or you wash it down with liquids to help it wash down. You can also have somebody go in and dilate the esophagus and the pharynx, and that will sometimes be effective. It tends to not be effective for as long as the surgical approach. And then there are some people that are not interested in surgery, and you can actually go with botulinum toxin or with a dilation and botulinum toxin, which will simply relax the muscles so that you can swallow better. It's also important to have a good exercise program. And in the past, we didn't talk about muscular dystrophy and exercise, but my general strategy is, as long as it doesn't hurt you, and so my general category is no P90X and no powerlifting programs, but mild to moderate aerobic exercise is very good. It allows your muscles to stay strong, and it allows you to, you can build muscle, whatever kind of muscle disease you have. You just may not be able to build it as much as if you didn't have OPMD. along those lines, it's very important that you have a good diet and you have an optimal weight. And that's true for everybody. But if you have weakened muscles in your legs, then the more you have to carry around, the harder it is for you. So if you have an optimal weight, it'll be easier for you to navigate the world. And then finally, things that we don't think about are breathing and sleep. So breathing is rarely affected in oculopharyngeal muscular dystrophy, and the heart is not affected in oculopharyngeal muscular dystrophy. However, when you have some weakness in the throat area, that can lead to problems with sleep and sleep apnea. And so it's important that if you have oculopharyngeal muscular dystrophy, that especially if you're tired all the time, you may need to have somebody take a look to make sure that there's not something they could do to help you sleep effectively at night so you'd be fresher and more awake and aware. So Maureen, I think I covered many topics that were relevant. Did you have others that you wanted me to touch on?
I have a few questions for you, Dr. Wicklund. It's really interesting to see myself and what you outlined and things that I had never really heard before, but you really brought it to light. So thank you for that. And I think it'll make a difference for a lot of people. So my first question, and some of these came from people who submitted them prior to the webinar, is there a reason for the adult onset of this disease? Has that been discovered yet?
Maureen, that's a very good question. And truthfully, for the last 15 years, for all genetic muscle disease, muscular dystrophies, I think I'm going to go back and just say the answer is no. But I'm going to go back and say there are two questions that are very key that we don't fully understand, which is one, why does disease start when it does? And why is it different, even in different family members? And I have some family members that have onset right at 40, and they go, well, my uncle, he was 60 before he had anything at all. And we do not know what those modifiers are that make somebody present earlier or present later. The other one that pertains to that we don't understand, and we for any of our muscle diseases, is that a lot of our muscular dystrophies affect particular muscles. Oculopharyngeal muscular dystrophy is very specific. It affects the eye muscles, the swallowing muscles, the lower extremity hip girdle muscles. But why doesn't it affect grip muscles? Why doesn't it affect certain other muscles? We do not know why certain genes lead to disease that cause certain muscles to be affected and others not.
Okay. Thank you. And just really interesting. I mean, I'm sure science will continue to find out more about that. Thank you for kind of walking us through what a journey looks like from your perspective. And, I think some really great recommendations for what people can take on. Given the nature that this is genetic, carried in families, if you're pre-symptomatic, is there anything that you would recommend? Because you're recommending exercise and diet and nutrition, but anything that people would do differently? Where I'm looking from is I was a collegiate athlete. And would that have made a difference for me in my journey as opposed to someone who wasn't that physical for that long in their life? You might not know, but I think it's interesting.
No, that is a very good question. And that is a very good question that we have brought up in a number of different muscle disorders. In general, we believe that there is not a big impact in prior exercise leading to either earlier or more aggressive disease of the skeletal muscles in patients with most muscular dystrophies. So that's my first answer to that question. As it is, the way I often chat with patients, I'll say, even if you were athletic, if you knew that 30 years in the future or 20 years in the future, you might develop this disease, would you choose not to live your life to the fullest at the time that you did it, knowing that it might make And if we knew that it made a huge difference, I would just say, okay, we have to think about it. But if it's going to make a difference, it's only going to be a little. And I think most people would choose to do what you did, which is live a full life and go forward. At some point in the future, if we know differently that there's a huge impact, then I would change what I would say, but I don't believe that we're going to find that.
Yeah, I think I'm even looking at the opposite of that. Would it have benefited me, like that I did do that, or that someone power lifted early on in their life and like maybe it had a more positive impact?
So my answer to that is I don't think that we know that that's the case. If anything, there's slight data for a few disorders that early onset of excessive activity may lead to earlier onset of weakness, but that's only for a few and not OPMD. The other important thing is there's a fellow, John Vissing, who does work with exercise in genetic muscle disease. And pretty much every genetic muscle disease he's looked at, exercise, even when you're in the midst of your journey through your disease, even when it's pretty significant, he's shown that you can improve muscle strength in those muscles that are still there. And so it's still worth doing some sort of activity. Again, I don't know if, P90X or powerlifting programs are appropriate, but good exercise is probably beneficial, for your heart and your life in general, but also for your muscle disease.
One more question for you. Thank you for being so thorough. So we hear a lot that people's medical providers know nothing about this disease. So what's the most important information that we can offer them as we take on this journey?
That's where I think the community has extreme value, because the community will know who knows about the disease and who doesn't. And I'll also say you have several people that need to know about it. Your primary care provider should at least be introduced to the disease. And in some of our disorders, we'll just say, here's a review article, take it to your primary care doctor and say, you should know about this because that's me. But you also, whoever is your neuromuscular person, whoever is your gastroenterologist or your ENT doc, whoever is going to help you with swallowing, and then also who is the person that's going to do the blepharoplasty. So I think it's important that you have a way to find out, and whether that's through your primary physician contacts or whether it's medical contacts or whether it's through, for example, the OPMD Association. That's a great way. And we have other advocacy organizations that have areas where they have providers or centers of excellence or recommended providers that you know about. And then patients can look across the country to find who's the closest person to them.
Yeah, I think it's really interesting the point that you just raised about just raising it with like your full medical team, right? That's actually how I was diagnosed. So my eyelids were drooping, but drooping eyelids ran in my family on both sides. So I didn't really think anything much of it when I went to get my glasses, re-upped. But then it started to become more of a problem the next time I went. They said, you should go see an ophthalmic plastic surgeon, which I did. And she's the one who queried what my background was and ascertained that I had a French Canadian background. And that's how I was tested. So I really do make sure that I don't gloss over my medical history with anyone, because somebody can contribute something to you along the way. That's completely been my experience. Like, I've found amazing treatments, which I can share a little bit about just by speaking about it to my community of people, including my care team. So thank you, Dr. Wicklund. Anything else you want to say?
No, I'm just pleased that this is starting up as a webinar that will get out to a number of folks, and I think that will certainly help them better deal with their journey while they're living with what they have, until we have some sort of definitive therapeutics that will help make it so that theoretically you'll have genome sequencing at birth, and then you'll not get the disease because it'll be gone by the time we'll CRISPR it away before you ever get it. How's that?
Mm-hmm. Thank you, Dr. Wickland. So speaking of living with, I want to introduce you to Melissa, who we introduced at the beginning, but Melissa has been newly diagnosed with OPMD just this year, in fact. And Melissa, I'd just like you to share a little bit about what your journey has been, on this trajectory, and what you'd like to share with the people in our community.
Absolutely. So first of all, thank you for inviting me to be on this panel. And I was just diagnosed this past January, just a few months ago. And while it's a new diagnosis, OPMD is not something that is foreign to me because my mother was diagnosed over 8 years ago and has been living with OPMD. Two of her brothers also have the OPMD symptoms. So therefore, we've done the research. We're living it right now, seeing my mom go through it. So when she was first diagnosed, Dr. Wickland is correct. It's important that our medical community is informed of this. And in the area that I live in deep South Texas, right on the Texas-Mexico border. No one was familiar with this disease. So therefore, my mother had to actually travel 8 hours in order to be able to finally receive the diagnosis. And after that, the neurologist told her that, well, she has this rare disease and that her children have a 50% chance of also being carriers of the gene. So he recommended that my brother and I also be tested. My brother did. He did the genetic test. It came out negative. I, again, decided to do it a few months ago and it came out positive. And at that point, even though I was prepared, you think you're prepared for the diagnosis, it still hits hard because, again, there's so many uncertainties, so many unknowns. And yes, while it doesn't affect your lifespan, it does affect your quality of life because, again, I'm seeing it right now with my mother, who, again, used to be very active in the community and in her church and pretty much cannot leave her home because of some of the symptoms and side effects that come with OPMD. So, back a few weeks before receiving the diagnosis, I went out to dinner with one of my best friends, and she asked me, she says, "Why do you want to know? Like, really, why is this important?" I said, that's a really good question. So I told her for several reasons. I said, number one, I know that the swallowing is something that's obviously pretty much, you see in it on the OPMD patients. And that was one of the first, I guess, symptoms that my family members experience, a choking episode, which can be very scary because you really don't know what is going on. Food is not traveling down or coming back up. So therefore, to me, I said, number one, I want to be able to slow down when eating because I'm very active, always on the go. So I want to make sure that I slow down, but that I also savor the food. What I did not mention is that my mom's been on a feeding tube for over the past 8 years. She can't even swallow her own saliva. So therefore, I never know if I get to that point, I never know what my last meal may actually be. So therefore, that was number one. Number two, I want to make sure that I keep physically active. And to me, I want to be able to travel and have experiences. And that's one of the things. I don't want to live with that regret. Like I should have gone here one more time while I could. And now I really, like you see it in the research in the literature, the ptosis, the swallowing are two of the predominant, I guess, symptoms, but I'm learning how it really affects different family members. And as far as the limb girdle, in my family, we don't see that. Again, my mom just turned 80. She does need a walker, but I'm seeing some folks in their 50s and 60s that are already struggling with the walking. And I'm thinking to myself, okay, I'm here. I can physically get around these people so desperately want to be able to walk and to be as active as they were before. I need to get up and just go out there and walk and exercise and do what I need to do to keep active. So that was the number two reason for doing this. Number three, I I'm an educator. So and I really believe in research. I believe in just really learning about it more. But also I thought to myself, if there are clinical trials, guess what? I'm a proponent of that. So I want to make sure I sign up for any clinical trials that I may qualify for. And the way I see it if there is no cure in my lifetime, I would hope that at least for my children, if one of them were to carry the gene, that by then there would be a cure, and I would be want to be able to contribute to that. So, and then the fourth one, and I'm so glad that I did this, is joining the OPMD Association, because again, sometimes you feel like you're alone in this, especially because they're so rare. It's so rare, and there are so few folks that are living with it. So to me, it was important to join a community. In my line of work, I advocate, especially for students, that I'm in education. But the way I see it, this is an opportunity for me to be able to advocate for individuals living with this rare disease, especially because I'm living it right now. So I know what it's like. And just the awareness, because again, it's spreading the awareness not only amongst folks, but also within the medical community. That to me is very important. So that has been pretty much my first few months of living with the disease. Fortunately, my symptoms, they're really not, there's certain things, like the eyelids, I've noticed, they're drooping a little bit. The swallowing, thank God, I'm good. But there are certain things that I notice. And to me, again, that's important. And thankfully, I found Dr. Wickland, out of San Antonio, who's my neurologist. Met with him, and it was very reassuring. And just like he did in his presentation right now, he was very thorough in terms of explaining and just giving me hope, pretty much. And I think that's what a lot of folks are needing, just that hope and that sense of community and knowing that they're not alone in this.
Thank you. Just thank you for sharing what it's been like for you. And you don't have to share this. I'm going to share a little bit myself. Like, I'm a pretty powerful person, but it was like a gut punch to get the diagnosis, certainly. And I did spin into a little mini depression over it. Because you don't really know what you don't know when
Exactly.
you're diagnosed with a rare disease. So, just what was it like for you, like when you really heard about it? I think that, people think that they're wrong because, they're upset about it, but um, it really is part of the process. And what was that like for you?
So it's interesting because my mother at that point, my mom does not leave her home. And at that point, she said, I really wish I could go to, we have a really beautiful island close to her, about 2 hours away from her home. She said, I wish I could go one more time and at least see the sunrise and the sunset. I said, absolutely, let's do it. So we went over pretty much, we did an overnight trip. It was her and my children and myself. So as we're on the road, I received an email saying your test results are positive. So at that time, I just said out loud, I said, "Oh no!" And she said, "What?" And I said, "I just got the diagnosis." And and my kids were in the back, and they said, "What do you mean?" So I started explaining, and I think I was very strong. But I'll be honest with you, that evening I did break down. After I guess internalizing everything, at the same time, I sent my best friends, my brother, some of my family members, I sent them a text, and right away they all started calling, "What do you need us to do?" Which I really love. I have that strong support system. So that evening, it's funny because I'm not much of an adventurous person, but we were out there, and my daughter said, there was a Ferris wheel. I want to get on the Ferris wheel. I said, you know what? Let's do it. I typically wouldn't have done it, but I said, let's just do it. Let's just do it. And so I want to be able to, take advantage of those experiences. But it was hard, and for the most part, I feel like I'm very blessed in that my symptoms are mild. And I didn't mention this, but 48 is pretty much the typical onset of when you start seeing the symptoms. Well, it was right as I turned 48, that month in January, that I received the diagnosis. But again, after taking part in various communities, online platforms, and support groups, I noticed that some folks are starting earlier in their 40s and seeing the symptoms progress faster. And then I see some folks in their 80s that, are struggling, but may not be on a feeding tube like my mother. So it's not like a one size fits all. So at this point, I'm considering myself very blessed, and we will see what the future holds. But I'm ready, and I'm glad I have like this support system, because
Mhm.
it really does give you peace of mind.
Yeah, thank you. So yeah, you raise the importance of community, whether it's your medical community or your caregiver community or the people around you, your friends. your family or the people in this community, it's really important that we just all stay in communication, right? We can make a difference for other people. That's what we're trying to do today, right? So um, that you can learn something from each other and know that, there's other people there that are on a similar journey. That's the first thing that I really gravitated towards on my journey is, okay, I'm going to research a little bit and I'm going to find out more about this because I don't really know anything. And I dug in a little bit deep. I actually went down into a little bit of a rabbit hole. But I came out of that rabbit hole, with some knowledge. And then it was just like, look, I live in New York City. I'm going to take on this diagnosis in this city and I'm going to talk to everyone I know to, kind of really see what there is that I can do. My own journey has just really been about testing different modalities. I mentioned before being a collegiate athlete. While I can't, I, while I can't compete at the level of like being a triathlete like I was before, or playing tennis every day like I was before either, um, I am quite active. I make sure I walk. I do Pilates. I do gyrotonic, like, weight bearing exercises, but they're light. And I also do something called muscle activation technique, which just I found out through researching a similar type of adult onset muscular dystrophy. So, just research and learning about other things are important. I've been doing muscle activation technique for almost 2 years now, and it really just resets me, and makes me feel strong and in my body, as do those other modalities, and that's what works for me. And the sleep and the nutrition, like proper nutrition, I upped my protein a lot, and I found that my body felt a lot stronger than it did before. Um, Always ate kind of healthy, but upping my protein really kind of made a difference for me. And I learned that, through a nutrition expert that I worked with, but I've also watched muscular dystrophy webinar, and that was the advice that they gave everyone with muscular dystrophy. So there's information out there in your community. There's people, if you're really just interested in kind of seeking out something different, it doesn't necessarily sit with a physical therapist or like a traditional modality that you're used to. There's other things that you can do to really take on this diagnosis. So that's what I hear you doing, which is really living your life. And then you really mentioned that you're advocating for yourself, whatever it is I can do, whatever I can, participate in research. It may not impact me, but it may impact future generations. And that really is a good transition to like the exciting news that there actually is a trial going on right now. And like that, that's magnificent. A lot of rare diseases don't have any kind of research going on with them. So I'm going to turn this over to Dr. Banks, who's going to share an update with us on the therapy that he's forwarding in clinical trials. And he's going to tell you a little bit about what's going on there. So thank you for being with us, Dr. Banks.
Much for giving me the opportunity to talk to you and hopefully other members of the community that are able to view the webcast. So my team and I put together just a few slides to give a little bit of background on the clinical study that we're currently working on and the drug itself, why we are excited and believe that the mechanism is well suited for the types of changes that occur in OPMD, and we'll share just some of the preliminary clinical data that we have. The study is early in terms of its conduct, but fortunately we have seen some encouraging signs in some of the first evaluations following the administration of the drug. I have to remind everyone that Benetech is a public company, and because of that, we will make some statements that are forward-looking. We obviously hope that all of the work that we're doing will be productive and safe and effective, but we won't learn. We'll learn that over time, and so we just caution people to be aware that we will make some forward-looking statements. We have had wonderful introductions from Dr. Wickland and from both Melissa and Maureen about some of the key elements of OPMD beginning in its earliest stages following diagnosis and over the course of progression in some specific cases. This slide is just meant to highlight some of those key messages. Again, we know that OPMD is a rare disorder, and like was discussed previously, while there can be weakness that develops in muscles in different areas of the body, what we heard when we began our journey of development for this potential intervention was that the most troubling element of the disease that patients experience focuses on the muscle weakness in the throat, and specifically over time, how that muscle weakness can make it more difficult to eat both foods and liquids. And if the disease progresses to later stages, that can make it more difficult to maintain adequate nutrition, and so it can lead to malnutrition, and in some cases it can lead to aspiration or food unintentionally entering the airway and the lungs. And so when we started to think about the best way to adapt the technology that we're using, one of the things that became clear to us based on our interactions primarily with researchers in the field and clinicians that treat patients is that we should try to focus specifically on the pharynx, on the weakness that develops in the pharyngeal muscles. And as Dr. Wickland said, because of the state of the art, we do actually know the disease, that the disease is driven by a specific gene, and the gene is called, it codes for a protein called poly-binding protein nuclear 1. The mutation was described by Dr. Wickland, and the point we always try to make is the key change that occurs in the muscle because of that mutation is the protein is produced in an aberrant form, in a harmful form. And it's harmful to the muscles specifically because it has the tendency to aggregate. And as those aggregates build up in the muscle, they can damage the muscle over time. And so we've tried to focus mechanistically on the actions that could be taken to alleviate the formation of those aggregates and then to simultaneously deliver a new normal or functional version of that mutant protein. This slide shows the diagrammatic description of the drug. The drug is called BB301, and it is a gene therapy. As was highlighted on the previous slide or during the previous discussion, there are two primary mechanisms that we've been focused on during the development of BB301. First, we wanted to design a drug that was able to prevent the formation of that mutant aggregation-prone protein, and a part of BB301, a part of the genetic construct, accomplishes that specific mechanism. And secondly, we wanted to make sure that there was sufficient normal poly-A-binding protein nuclear 1 delivered to the muscle. And the other component of BB301 carries out that primary function. So in total, there are 3 genes that are carried inside of what is essentially a virus. It's a re-engineered virus. But it's important to note that this virus is part of a family of viruses called AAV, and that family of viruses has been used in more than 200 clinical studies and has been shown to be safe, and that is always our primary concern. So we chose that family of viruses to deliver the 3 specific genes that make up BB301. It's also important to note that the method of delivery it's carried out in the operating room. It's a relatively short procedure, but the procedure is conducted under general anesthesia by an otolaryngologist or a head and neck surgeon, and that the procedure itself allows the surgeon to directly deliver BB301 into the muscles of the pharynx at a very specific dose and in very specific anatomical regions of the pharynx. As was discussed previously, there can be a variety of elements of the clinical presentation, but one thing that we heard consistently, and we started this work approximately 10 years ago, one of the things that we heard consistently was patients may have a variety of symptoms. It can depend on the patient themselves, the stage of the disease, or many other factors. But generally speaking, almost all patients develop problems with swallowing. And so when we were deciding about the ideal muscle group to begin our work on, we focused in on the muscles that drove the development of dysphagia. And so this slide is just a summary of a relatively recent study, an observational study that was done in approximately 300 patients in Quebec, where patients with the diagnosis were observed and their specific symptoms were outlined. And again, it's important to note that in that group, approximately 97% of the patients did have trouble swallowing. We also like to give just a brief background on the process of swallowing itself. It's obviously important, but we wanted to make sure we link the process of swallowing to the chosen intervention and the method of intervention for BB301 specifically. And so here we just remind everyone that in the absence of any swallowing problems, what typically happens when you ingest food or liquid is once, in the case of solid, once you're finished chewing, the food and liquid potentially will leave the oral cavity and enter the pharynx or the throat. And once inside the throat, there's a highly coordinated sequence of contractions of a specific group of muscles called the pharyngeal constrictor muscles. Those muscles are very important because they close the tube or the pharynx, and that act of constriction propels the food or liquid through the throat, downward towards the esophagus, and then ultimately there is a muscular cover over the esophagus that relaxes and allows the food or liquid to enter. In OPMD, there has been a tremendous amount of research done on the specific muscle tissues in the pharynx, and what is known is that those pharyngeal constrictor muscles become weaker over time, and they can atrophy, essentially becoming weaker and smaller over time. And that's important. Specifically, it was important for us in terms of planning the development process for BB301, because when in the earliest stages of development, when we tested the drug in animals, what we noticed was that when BB301 was directly injected into skeletal muscle, after there were 2 time points that we observed. So after 3 months and then after 5 months, we noticed that the muscles that were injected, and these are animals that have the same deficits as patients, as human patients with OPMD. It's an animal model for OPMD. But after the injection of BB301, the muscles got bigger, meaning the cross-sectional area of the muscle increased, the mass of the muscles increased, and we specifically measured the force that those muscles could generate in this case in animals that had received the drug as compared to animals that had not. And there was a very meaningful, statistically significant improvement in the amount of contractile force that the injected muscles could generate. And we hypothesized that if we are able, and this was many years ago when this study was done, but if we were able to safely advance BB301 into clinical studies, and we were able to see similar improvements in the muscles of the throat, that could potentially lead to an enhanced ability for patients with OPMD to swallow, because it would allow those muscles to get bigger and stronger, to contract more forcefully, and then hopefully to clear food through the pharynx more efficiently. And this slide is a high-level overview of the clinical study that we're currently conducting. We are deeply appreciative to all members of the community and the clinical caregivers that have shown interest in this study, subjects that have enrolled, families that support the subjects that are enrolled in the study, and just for the general very, very broad support that we've received from the community. We're very thankful for that. And we know that people have questions about the study, and so we'll try to answer some of the general questions here. The overall structure of the study is shown here. The key point, I guess the first key point would be there are two parts of the study. The first part, shown on the left, is what we call the natural history study, and it's a study that can run at a minimum for 6 months, but subjects can stay in the study for up to 12 months. When people enroll in this study, what they can expect is that at their clinical visits, so at a minimum, they will have 5 visits to the clinical trial site before any drug is ever given. So in this first part of the study, it's observational. And the reason that the first part is purely observational is because we want to make sure we understand, and importantly, the principal investigator, the doctor who's managing the study, we want to make sure that they and their staff understand the baseline level of swallowing that each subject presents with. Patients, we define entry as, we define the study as being appropriate for subjects that have moderate swallowing difficulties, and there's a specific definition for that. But once in the study, subjects will come to the clinic at least 5 times, and there are 3 basic things that will happen. The first, in terms of the assessment of their swallowing, is that they will fill out what we call a patient-reported outcomes survey. And this is a 17-item questionnaire. It lists essentially every type of food or liquid that a person might encounter in their daily life, and it asks them to rate the level of difficulty that they experience when they encounter these foods or liquids. So the first thing they do is they sit, and it's the patient fills out the form on their own, so that it's the most objective from the patient's perspective. It's the most objective representation of how they are feeling about their ability to swallow. The next thing that happens is that there are swallowing studies that are done with liquid, with water primarily, and Dr. Wicklund outlined these as part of the standard diagnostic procedure, where patients will drink different volumes of water, and they are timed. And it's reported in the literature that as the disease progresses, it can take longer to drink fixed volumes of water. So we assess those. But probably we would say the 2 assessments that we focus most on are the patient-reported outcome of the survey and a series of X-ray based swallowing studies. So Dr. Wicklund mentioned this. he talked about the importance of having swallowing studies done by a radiologist and a speech language pathologist. That's what we're describing here. The important or the most important point is at each of the 5 visits, uh, patients that are enrolled in the study will be presented with 4 types of food and liquid. And the consistencies range from water at the thin end of the consistency spectrum and increase in a way that we describe as a consistency that's like a smoothie. That would be the next thickest substance. And then a liquid that has the consistency of pudding. It's basically pudding. And then finally a solid food. And at each visit, a series, essentially a movie, an X-ray based movie will be taken while the patient eats or drinks those consistencies, and that will be recorded and interpreted. By the end of visit 5, that this team that's managing the study, the clinical team, has a very good idea of the substances that are most difficult for each patient to swallow, and they chronicle that in the medical record. After the month 6 visit, the patient can then screen to receive BB301. And the procedure to administer BB301, it's a 1-day procedure. It happens in the operating room. The procedure takes about an hour. I can tell you it's shown on this slide. 2 subjects have been safely and successfully administered the drug. And so the procedure itself has been executed successfully. And after the receipt of the drug, over the course of 1 year, the patients will come back to the clinical site 4 times, and the exact same assessments will be carried out, meaning the patient-reported outcome survey will be given, the time swallowing studies will be administered, and the X-ray based swallowing tasks will be carried out. And the reason for doing the identical assessments after the drug is given is to allow us to determine if there's an improvement for any of the consistencies. And so this will allow us to do 2 things. For every subject that enters the program, they will have the ability to receive the drug. But we will also have the ability, from a statistical perspective, to determine if there are benefits across the doses. One thing that's not shown on this slide and is important to mention is currently we're testing dose 1, and there are three doses that we endeavor to test. So currently we're testing the lowest dose. We would expect to begin testing the next dose by the middle of next year, and then the highest dose sometime after that. But the most important data point to mention is that there have been no safety concerns because we are testing an investigational agent, so that's the most important thing to highlight. For the patient-reported outcome measure, which is the 17-item questionnaire, we've seen very meaningful improvements, and we compare specifically the 3-month, so these red diamonds indicate a 3-month visit, a 6-month visit, a 9-month visit, and a 12-month visit. So for the 3-month and the 6-month visit, we've seen very meaningful improvements for the patient-reported outcome measure. And similarly, fortunately, we've seen that corroborated with the X-ray based swallowing studies. So we've seen very meaningful improvements in the ability of the first subject to clear food through the pharynx and to empty the food into the esophagus. And in addition to the safety, the benign safety profile, this was very encouraging for a few reasons. One, this is the lowest dose of the drug that we'll test. So in the animal studies, all of the doses that we tested were highly efficacious. They meaningfully improved muscle strength. So we had a scientific reason to be enthusiastic about the potential for all doses to help patients, but it's very encouraging to see in the early testing that the patient reports that they are feeling better about their swallowing, and the X-ray data, the X-ray-based swallowing studies, corroborate that finding and provide support for why they report feeling that way. And so I'll stop there, and if there are any questions, I'm certainly happy to answer them.
Thanks so much great information just to see the process of how all this happens. Like it's just, you don't really know what happens behind the scenes as something's coming, being investigated to potentially come to market. So thank you for sharing all of that with us. I have a few questions just based on your presentation. I mean, I would say not based on your presentation, but that I was thinking about after our presentation. So, um, would something like this potentially lead to therapy that could impact the whole body? Or is it only something that intervenes where it intervenes in the body?
So currently, and that's a critical question. We internally we thought a lot about the best first use of the agent, and then potentially how we might evaluate additional benefits over time. And we talked with regulators about this as well, and that's the reason for the slide where we show that dysphagia or swallowing difficulty is really a common issue. So we started there, and there are different approaches in the gene therapy space. Many of the approved drugs. So one of the approved drugs is approved for a rare form of blindness, and they deliver directly into the eye. So they take a direct approach to the organ or to the tissue type where they know that the impact is most pronounced. But then there are several other drugs approved where they use an IV. They deliver it intravenously, and to your point, Marie, it travels all over the body and can potentially be delivered to different tissues. For this first study that we're running, and essentially for this first part of the development, we would expect the effect to be limited to the pharynx. But also to your point, we've had clinicians reach out, and we reach out and bug as many doctors as we can to ask about the best paths forward. And they've mentioned two things. One relates to, I think, what each of you has discussed relating to ptosis, where there can sometimes be a requirement to do a repeat procedure. The muscles, there are publications that demonstrate knowledge about the specific muscles in the eyelids that are impacted, and they're skeletal muscles, just like the muscles of the pharynx. So scientifically, it could make sense to deliver the drug to the muscles of the eyelids as well. And then what we heard from some regulators specifically was related to that publication and it's just like Dr. Wickman said, that publication follows those 300 patients over time, and it shows exactly as you said, Dr. Wickman, 5 to 7 years later, some patients will start to experience weakness in the lower limbs. So it is possible to deliver directly to those muscles as well. So we think scientifically and mechanistically that there's rationale later to explore delivery to the eyelids or other muscles. We're starting the process and expect the effect to be limited to the muscles of the throat.
Oh, terrific. I mean, so there is like so much possibility here. And just for people's benefit, if you could just briefly explain what next steps are. So you've really very accurately described where you're at. But when you do something like this and you take it you take it and you really go to market with something, what are your next steps out of the successful safety and tolerability study here? Where would you go next?
Sure. So what we said publicly, essentially we've highlighted we've highlighted two potential paths. So traditionally, what would we do? And we by we I mean a gene therapy company focusing on a rare disease, because over the recent, I would maybe over the last 5 to 7 years, we've started to get practical information about what the regulators, specifically the FDA, expect. It can sometimes be different from specifically the sizes of the studies that you are required to run as compared to a medicine for heart disease or some other more common indication. So what we've seen is that gene therapies have been approved in after testing in about somewhere between 30 and 60 subjects. And after following the subjects, so they will have repeated clinical visits over about 18 months. So that's our baseline. And what that would mean is right now there are 23 subjects enrolled in our overall program. And we would treat those subjects across the 3 doses, collect the data, present it to the FDA, and ask what the next study, meaning the study required for approval, would be. And that's the baseline. But what we've said publicly is we hope to do, or what we will do this, but we don't know what the outcome will be. So we are encouraged by what we're seeing at the low doses. We will reach the second dose by mid next year. And so we would hope to take the data from those 2 doses, and that would represent approximately 9 patients. And just like you said, Maureen, as long as the safety continues to be benign and the drug is tolerable and we see evidence of improvement, we would go to the FDA in early 2026, which would be before we finish this first study. It would sort of be in the middle, and we will ask the FDA how they think about the data that we've seen to date, and ask maybe if we could more clearly define the path towards approval, potentially broadening out the current study or potentially opening up a few additional sites, maybe to get up to 60 patients, and then use all the data collectively to support approval. So that's how we think about it. Oh, please.
Oh, one more thing, and I might have missed it in what you presented, and you may not know yet. But once you administer, is it meant to last? So when Dr. Wicklund was talking about getting surgery for the eyes, right?
Yes.
Like, yeah, it doesn't often last. Is it meant to last?
It is. I apologize. I did not make that point. And so a couple of points there. The 2 mechanisms that are built into the drug are meant to last. We say forever, but we have to measure that. But the reason we expect long-term efficacy is that skeletal muscle cells don't turn over even if a muscle gets smaller, it's still there. And that's relevant for a few reasons. So you deliver the gene, it sits inside of the muscle, and it expresses the molecules that carry out those 2 mechanisms. As long as the muscle cell is there and functional, all of those new proteins will continue to be made.
Great. Well, thank you. Dr. Wicklund, anything not to put you on the spot, but anything from you?
From my standpoint, no, it's very exciting that we've got gene therapy, and focal injection is often safer in terms of approval by the regulators, which is a smart move. And so once it's approved in a focal capacity, that also makes it easier to think about doing a systemic trial. And so I think it's exciting that it's going to move forward.
Yeah, very bright future. Thank you. So I just want to thank you all for being with us today to make a difference for a community of people that really crave information, resources, and just time from people. It just all of that really makes a difference. So, Dr. Wickland and Dr. Banks and Melissa, I really want to thank you for your contribution today. And I want to thank the OPMD Association for sponsoring today's webinar. And I'm going to toss it to Michelle.
This webinar is possible due to the donated time and expertise of Maureen Costello and her team and our OPMD volunteers. We also want to thank Dr. Matthew Wickland and Dr. Jarrell Banks for their presentations, and Melissa Lopez and Maureen Costello for sharing their OPMD journeys. They are all exemplary advocates, champions for the OPMD community. The OPMD Association has accomplished quite a lot this past 2 years, accomplishments which are due to the direct support of our donors, our volunteers, clinical partners, and other nonprofits. Note the link to our website, opmd.org, where you will find resources, important dates, and opportunities to advocate for OPMD. We have also listed the link to Maureen Costello's documentary. Please make time to watch this incredible film. In closing, I'd like to invite you to become an advocate for OPMD. Partner with us to defeat OPMD in our lifetime. Thank you.